fluid I have. And since you're not removing this fluid from my body, now my heart is saying I'm having to pump a lot against a higher pressure because I have so much volume in me that I'm not able to keep up. And when the heart can't keep up, what happens? That fluid has to go somewhere. And what it ends up doing is spilling back into the lungs, which makes the lungs like wet sponges. And if you can imagine breathing through a wet sponge, it doesn't work. And so it's a vicious cycle, because then since the lungs aren't working well and getting oxygen into the blood, then the kidneys are sicker. And so you get this kind of avalanche of each organ one by one saying, I've been doing this for 60 years. My reserve that I had to give you was very thin, and you've pushed me over the edge. And so in medicine, we have a number of different, things in our toolbox that we can use, that we try to use, but ultimately we can never mimic what the body was naturally designed to do. We fall short every time. And so the goal is to catch you before your reserve is met. But that's what makes it difficult, particularly with those who have comorbidities, long-standing comorbidities, in that if your lungs have been battling against air pollution since the time you were a child, right? And you're now 50, 60, 70 years old, they can't afford to take that second hit. And that's what we're seeing is the problem.
Well, and that goes back to treatment, testing, and tracking. So we know that communities of color are going to be more impacted because they've been under more stress longer. And, tonight, many communities are out there protesting the death of George Floyd and the overt racism that led to his death, and the overt racism that is in communities that outright kills people. But what we're talking about tonight may be just as important. I don't want to say just as important, but also important. Yeah. So we know that there are studies, for example, that women, when they report pain, are taken less seriously than men, and that women of color are taken even less seriously. So they aren't able to get treatment in the same fashion. So when we're in this healthcare crisis, we need to reform our system of healthcare, period. But what can we do as municipal officials, as county officials, as state officials, as voters? What can we do to try and remedy some of these issues now in the short term with COVID, but in the long term with the healthcare system?
For sure. I think, you make a couple different points that I think run in parallel. For one, we know implicit and explicit bias exists within the healthcare system, hands down. And what I mean by that, African Americans, for instance, have higher death rates for 8 of the 13 leading causes of death. Again, health disparities, racial health disparities didn't start or stop here. There's studies even looking at it, University of Florida, I want to say it was the year 2015, they looked at 26,000 charts of patients that came in with complaints of chest pain and complaints, and were found to have what we call an elevated troponin, which is an enzyme that if you have signs of heart attack or at least heart strain, this enzyme is high in your blood. And so what they wanted to see is that of these 26,000 plus patients that come in, if they all complain of the same chief complaint of chest pain, and they all have the same elevated blood value, which ones actually get a heart specialist ordered for them to come and see them, and which one actually has a test that goes to look at the arteries of the heart to make sure they're not having a heart attack. And what they found with that 26,000 patients was that statistically, if you're African American, you are less likely to even have a heart specialist even consulted for you. You're less likely, definitely, to have a procedure done to look at the arteries of your heart. When we're looking at even infant and maternal mortality, what we know is that in 2006, 16, I think it was, Dr. Keisha Edward Bentley released a study out of Duke that looked at what is the rate of infant mortality. So basically your child dying before their first birthday, based on a mother's race and her educational level. And what she found with that, and this was nationwide, but what she found was that me as a double board certified anesthesiologist, it took me 13 years past high school to get to that level. But yet, despite that, my child is twice as likely to die before their first birthday than a white woman with a 4th grade education. And in looking at it, my child is 5 to 7 times more likely to die than a white woman with my same level of degrees. And so it's one of these situations where you can't even attain your way out of it. You can't, race is literally an independent risk factor. And so the same goes for when you're talking about George Floyd, of how do we hold law enforcement responsible to take care of every citizen in the same way, is the same way we need to do for healthcare policies. And so one of the things that I think we should start doing is literally reporting per physician a report card of what are your outcomes. If we're talking about, an OBGYN, for instance, you can give a report card for what are your standings on women that you offer a vaginal birth delivery versus a cesarean section, and then compare that ratio to a de-identified, what is happening with all the other physicians in your department, what's your department's average, and then compare it to the national average. And then every quarter we have to go in and look and say, where are your outliers? And instead of necessarily targeting that position, you can say, let's determine what the weaknesses are and plug in resources to fit that void so that we can correct this balance. And so we can stop just reporting the statistics of, yes, African-American women die at 3 to 4 times the rate in the peripartum or the around the time of pregnancy than white women. And we can stop reporting that as a fact and start fixing it. So I think as far as individual citizens, it's the push and demand of elected officials like yourself, who you advocate clearly for your constituents, holding things like this. Not every, person that's running for an elected position actually cares to hear from people. I think they kind of shy away from wanting to actually hear the comments. So I think engaging and saying, we need our voices to be heard, because we truly are only as strong as our weakest link. So we got to take care of each other.
And we'll open it up for questions in just a minute, but we know, like, for example, in our school system, right? You cannot hold a teacher responsible for an outcome when you have children who are in homes with domestic violence, who are not receiving proper nutrition, who are not even living in a home, maybe they're homeless, right? So we know that if we can get the data, we can fix outcomes by working on inputs, right? It's not a mystery where people who have to combat pollution and homelessness and poverty and lack of nutrition have poor outcomes in health. I think I really wanted to host this now because some people, and I've talked to other elected officials, and they aren't aware of this, right? Mm-hmm. They aren't aware of systemic racism. They aren't aware that the frontline workers are not living in our city, right? Maybe they're going home at night to a situation where there's a lot more pollution, right? So, and our frontline workers are going to be more exposed to the virus. They're likely to not live in a wealthy community because when I say frontline workers, I mean like our janitors, right? Who are cleaning our offices and who are cleaning our hospitals. We're seeing these deaths even in our own county with a lower, I'd say, percentage of people of color. We're seeing it affect them much more and much starker. And so people have to pay attention now, right?
Right.
And now's the time to say, this is when we have the data, we can fix it. So going back to testing and tracing and treatment, we know where our communities of color are.
Mm-hmm.
How can we bring resources in relation to the effect on those communities to prevent these outcomes?
Directly like that. We are, so in looking at you guys' number, and I might get the names of this because I'm country, but Santa Ana, is that
No,
it?
that's right, Santa Ana.
So Santa
Right.
Ana and Anaheim had two of the highest caseloads when I looked at Orange County. And, you know, it wasn't surprising to me. Santa Ana is 76%, I think, listed as Hispanic, and Anaheim, 54% Hispanic. In looking at the poverty, they also had lower income levels in those communities. I think Santa Ana had 4 of the 10 poorest areas within Orange County, and then Anaheim, I think, was had maybe two zip codes that were in that bunch. And so we know that it falls along the lines of, unfortunately, I feel the essential workers, those that you're speaking of, the grocery store workers, the janitorial staff, they're the hardest working people. They're underappreciated, they're underpaid, and they're overlooked. And what we know, there are a couple of things is this. For one, in Virginia, I can even just report what we post on our Department of Health page, is that we looked at how many people, what racial demographic and ethnicity presented to the ED with complaints of COVID-like symptoms, how many were admitted to the hospital. And what we saw was that Hispanic patients were presenting to the emergency room with complaints of COVID-like symptoms at far higher rates, but yet were not being admitted to the hospital, right? And the question I had literally in the beginning stages of this, back in early March, like March 5th, March 8th, I started to tweet the CDC and the World Health Organization saying, I need you to release your data now, because we know racial health disparities will exist, but I don't want you to just release data on who lived and died. I want you to go back further than that. I want to know, when people present to the hospital with complaints of symptoms, we give them a code. So for instance, if you have a headache, let's say it's code 10. If you have a rash on your hand, it's code 15. So every time you come in for code 10, we can look in the system and say, how many people presented with this headache? What's code 10? I want to know, based on the ICD-10 code that talks of shortness of breath, chest pain, cough, all those COVID-like symptoms, what percentage of those were actually given a test in the first place? Because you see, what can happen, you can have testing bias, where if you have for instance, a Hispanic male or a white woman present with complaints of chest pain and coughing and shortness of breath, do you give the test to this person or that person? Were they just sent home and said, just assume that you are COVID positive and just isolate yourself?
Wow.
And the problem that we know, like I said, with the essential workers particularly, they're getting hyper exposed to many different people that are coming into that grocery store, for instance. And so 1 in every 6 Hispanics can actually work remotely at home. Only 1 in every 5 African Americans can work remotely at home. So they are out in the public getting exposed repeatedly. And there are studies now looking at healthcare workers, for instance, that have that multiple exposures of COVID-19. And that's what makes us at higher risk of dying from it. We think is that you're getting multiple doses. And so with the essential workers, my question is that same thing happening, where they're getting multiple doses, not only at work, but then they're coming home, where they're all now coming back from the cities that they went to go work back into that one community. And it's dose after dose after dose after dose. So you're getting multiple hits, and then you're not getting tested for it on top of that. We know there are studies now looking to show that racial minority groups, where even if you are screening positive, meaning that we ask you questions and your questions are suggestive of COVID, you're less likely to get the test. And the opposite is true for our white patients, in that you can be screening negative, meaning that you really don't have the signs and symptoms of COVID-19 that push us to say you should get a test, but yet you do. And that's an issue we truly are going to have to come to terms with, because again, when you don't take care of that targeted population, they are the essential workers, and they will allow this to spread across the nation. So.
Well, and as a municipal official, we're making testing available, not just to the residents of our city, because as you pointed out, we have much higher rates of COVID in Anaheim and in Santa Ana. Well, guess where a lot of those workers work? In the city of Irvine. And so we don't have any information about whether, for example, a Costco worker who might live in Anaheim and work in Irvine got sick in Irvine and made others sick. Well, I don't want to say made others, but, you know, spread, the infection spread. And, you know, you talk about vectors and where that goes. So it is important to us that we test as often and as much as possible so that we identify where that is. Now, one of the figures that has been concerning me is the rate of positives in our testing. So we have we fluctuate between a 3 and 4% positive rate on our COVID testing. And I know in the data that I'm looking at, it says that that's too high. It says you're not testing enough people, therefore. So number one, could you explain that? And number two, can you give us some sites that you rely on to understand this big issue?
Right. And that's the thing when we say it's too high, we honestly don't know if it's too high. What we initially said was 1 in every 3 Americans will have COVID-19 before this is over with. That was the original push out, just because of how truly contagious it is. It's far more transmittable than the flu, and it's 10 times more deadly. And so, you know, it is one of those things. We know we have to test often, but the difference with this test versus other tests is that you literally can get infected every day. And I'm not sure how to say that in any other way, but that you can test negative on like, for instance, we did a community drive and I tested, or helped to test, I didn't test all of these myself, but 165 patients or people in our community. And, you know, I called them on Monday and gave the results to those who had tested positive. And then we called the ones who had tested negative. And in us calling to talk to them about testing negative, we had to say, you tested negative on Saturday, which has nothing to do with Sunday and has nothing to do with Monday. And again, just because you tested negative doesn't even truly mean that you are negative, because we have these false negative reports. And so, you know, we say continue to still wear masks, continue to practice social distancing, of which 6 feet is it's an arbitrary number. It's not like we conducted randomized controlled trials to see if 6 feet was better than 10 feet. We're just saying just to stay far away from people, if that makes sense. But it is one of those things of we can never test enough. And it's not only the test in numbers, it literally is, what tests are you using? So I would push you to go and ask them and say, with the company that we're using, if we're using something like Abbott now, they use contrived samples. So they use contrived sample, meaning that they had in the very beginning, when we didn't have a large population of positive people that we could test and say, oh, if this test comes back negative, we know it's wrong. We use contrived samples, and those are fixed samples that we use in the most ideal situation of where we're getting this in a lab, it's in a controlled setting, we know there's no contamination, and this is the most perfect situation. When we're in the real world, though, those things change, right? And so whether or not you test positive has to deal with a number of different factors. One factor being, when did we actually test you? So the sensitivity of that test, as far as it being trustworthy in its result, depends on a viral load that you have. So let's say that you started getting really, really sick on Monday. but you were so sick that you couldn't bring it to yourself to get out of bed. You felt lousy. You could barely move. And so by Friday or Saturday, you're now starting to feel better, right? And you're like, man, that had to be COVID. I'm going to go and get tested. Well, it may be that by the time you get enough energy to go in and get tested, now the viral load that you're shedding is low and too low for the sensitivity of that one test. So although you are infected, it may read that you're not. It can be the opposite way too, of where, let's say your husband or your best friend calls you and say, oh, I tested positive. And you saw them that Saturday and now it's Monday. And you're like, well, I'm going to go get tested. So you go get tested then and say, I had a positive contact with someone. They are in the hospital right now, sick. I know they have COVID. I was in their face on Saturday. On Saturday. Well, we could test you then. But if your viral load, if you're not really too symptomatic on that Monday, we may say you tested and you're negative, but by Wednesday or Thursday, that's when you may start to show signs and symptoms. And that's when you would have a higher likelihood of testing positive. So the viral load and the timing of the test matters. And then where we get this sample matters too. You'll see all these pictures of us going in the nose and you know, Trump was saying how uncomfortable it is. Well, the reason why we do that, that little flap in the back of your mouth that you can see when you open really wide, the uvula, that helps to trap a lot of secretions. And so when we go into the nose, we get actually right behind that area spot, kind of, for lack of a better word, and it allows us to get a better sampling. And so the sensitivity of getting a sample through your nose, although it is really uncomfortable, it's the most likely route that if you are positive that we can get that. If we go inside the mouth, it's a little less, right? Because, and definitely if you go get a testing site and they just rub the very inside of your nares, I wouldn't trust it if it came back negative. That's just not the proper way to do it. And so
that's the test that I had.
Right.
That's the test that I had, because I know I was expecting to get one in the back of the nose, and we had some really good questions in the chat. So and it's all on testing. So they had me test as an essential worker, as a city person. And I went in and I was expecting to get the back. I'm like, oh, you're going to jab me in the brain. Like, no, they just, scraped the back of my neck. I was like, okay, back of my throat. So, right. And then we've also had an experience at the city where we are not going directly to the laboratory to order a test. We have to have a middle provider, who then orders the test, maintains the chain of custody, and we're finding problems in that chain. But the questions that we had in the chat were, do we in the US have a reliable test? And I think you answered that, but can you walk through the ones that you rely on and walk through again, like which ones that you would recommend?
Right. So, I mean, we do have like I said, the one that got the biggest notoriety was the Abbott Now. And I want to say it could detect down to 100 or to 10,000 copies per cc. So what does that mean? So we get a sample and what we rely on is PCR. So PCR is this ability to make multiple copies, if you think it like a printing machine, of whatever sample it has of the genetic code. And so this Abbott test could detect down to, if you had at least 10,000 copies per cc of that virus. And that's a lot, especially when you hope to be able to detect with the smallest amount possible. Right now at the University of Virginia, we actually use Abbott M2000, and that can detect down to if you only have 100 copies per cc. So that's a lot better, as you can imagine, that you should be able to detect someone that maybe is not as symptomatic. They don't have that high viral load that we talked about, that you may still be able to get that, that sample for the person. Now, the problem is that nationwide, and literally hospital to hospital, even within the same zip code, who we contract with versus who they contract with is different. When we're having these community drives, and organizations led by different municipalities. It depends on what company they went with for that testing site. So that's the problem. I actually called the FDA because I had time. Like was that on Friday before our testing event, because I wanted to ask them and push them to say, I see you have this listing of tests. Have you, now that we have known positive people within the United States, gone back to these companies and said, we need you now to go through the proper validation for these tests to show that when you're given this negative result, that you tell this person that, no, you don't have the virus, that we can trust it. Because what we know with COVID-19 is that the symptoms vary all over the place. You'll have some people complaining of GI symptoms, some people complain of headaches, some people complain of loss of taste and hearing and smell, and others have the typical chest pain and the shortness of breath, and then some people have no symptoms at all. Matter of fact, of the people I had to call that were positive, 3 of those persons had 0 symptoms, right? And so when businesses are starting to think about opening, they really will want to try to rely on a test if that's possible, and only makes sense, right? Because the other thing that I've seen a lot of people do are literally checking everyone's temperature, and I wish that goes away. That's another one of those things that I wish we never said in the beginning, because there was a study out of New York City of 5,777 patients, and only 30% of those who tested positive for COVID actually presented with a fever. So that's a big gap of people who will not have fever. And so to use that as the ready test when you're having your workers come back into the small business, that's not enough. And that's why, again, I say we don't have the 3 T's. We definitely don't have the treatment thing down pat at this point, and we don't even have the testing down pat. So we have to, as a nation, say, as uncomfortable as it is to wear this mask, as annoying as it is to not be able to truly have social interaction, in order for us to make it to December as a unit, because we know right now, I think the last count I saw on the Worldometers count was 103,000 Americans have died, and they won't be here for the holidays. And that's a real fact, that are including babies, and that's including 10, 11, 12-year-olds, is including 20 to 40-year-olds, is including our grandparents. And beyond that, we talk a lot about the ones that have died. There's of the closed cases, we have about 83% of those we call recovered, right? Well, here's the thing. Those recovered people include those who've had massive strokes, who've had massive heart attacks and are now with heart failure, who have had permanent lung damage and now have to have oxygen permanently with them, who have had permanent kidney damage and are now dialysis dependent. There are people that have had blood clots that have gone to their arms or legs and have to have amputation of their limbs. So when we say that 80% have recovered, that does not mean that life went back to normal for them. And I think that is probably the biggest misconception that's going around with COVID-19 that no one ever mentions in the news.
Yeah, and a good point was made in our chat about why are we doing testing drives. It seems like that's an equity issue, particularly with people with no health insurance. I know it was important when we voted in the city of Irvine. It's very important to me that testing is given to you regardless of your situation with insurance. If you have insurance, please bill your insurance, and so that we can get reimbursed. But we're testing everybody. I mean, and that's why I think the disparate effect on communities of color is finally important to people who were not previously paying attention, because the people of color who are in our lives as workers are now, their health is impacting everyone's health.
Right.
And so my last question before we end tonight is, what can we do equitably? I think Cherry Lai put in the chat, like in Taiwan, no matter whether you're symptomatic or asymptomatic, if you test positive for COVID, you are isolated, and you're isolated in a hotel if you can't be isolated elsewhere, in your own home. There's other family members. So can you talk a little bit about what we could do? Because we have made money in California available for hotels.
Right.
For people. So can you talk about how that can help us get out of this?
Right. I think so definitely making resources available as far as hotels, whether that's Airbnbs that you now say, if we're truly trying to support, the common man, hotels, they definitely going to get bailouts. We see the trillions that are going around into these big corporations, but we also know there's true Americans that are struggling to make ends meet, and thinking about those who are in the Airbnb and the bed and breakfast type settings, to say, is there something where we can have where if people can't, they're trying to do the best they can do, they can go and isolate. Keeping in mind too, there are a lot of single parents. And so if I'm sick and I have 2 or 3 kids, how am I going to make sure that my children are going to be taken care of? Because I don't want them to be one of the children that ends up with this, post-inflammatory syndrome. So those are things, getting food to people. But also when we're talking about testing, I think particularly for the Hispanic population and more specifically to the undocumented immigrants, what we have to remember too is that these individuals are truly hardworking and truly are the ones that are helping to keep our nation afloat and keep our food supply chain in system. And yet we have to really make sure that when we're going out to do these testing drives, that the messenger matches the audience. We had an issue where we were deploying and making use of the National Guard, of which my father's in the Army, and I very much appreciate the service that our military offer. But we also know that there is now this relationship, particularly within the last 3 years, of where there's a distrust between government and undocumented immigrants, as rightfully so. And so if you have, the entry of the National Guard or people in uniforms into those communities, that's a huge flag of, I am not going to this, because ICE may be there to deport me away from me and my family when I'm simply just trying to go get help. So we have to be very real about the message we're putting across, making sure, in Orange County, you guys do have a very diverse population. In Charlottesville is black and white. It's pretty much, we're pretty bland over here. But you do have a high population of Hispanic and Asian. And so making sure that you're covering all languages as well. Orange County has 11% poverty rate. And I'm not sure what the literacy rate, I couldn't find that on the websites, but in looking to make sure that the information that we're distributing in communication matches for everyone that calls Orange County home, making sure that it's available not only in the social media branch and things that require Wi-Fi, but also, like in South Carolina, 1 in every 5 homes are without Wi-Fi or any form of like a laptop, right? So, as far as our children goes with education, but that being the case, the types of media, it has to change and be very fluid, and you may have to say the same message in 3 or 4 ways. For African Americans, again, with George Floyd being fresh in our minds, we may have to know that an African American male, when you tell him to put on a mask and walk through at night and have the audacity to say, why aren't you doing that? It's because I'm scared of being shot. I'm scared of being killed. And so we have to be aware of that. We have to be aware that the Asian community has been targeted by these racist comments of this being the China virus, as if that does anything to help benefit anyone, and the targeting of them, and how does that make them feel about, again, coming and seeking help to say, I think I have this, in the fear of someone saying, well, you caused it. when that shouldn't be. And so we really have to think of the approach holistically. Know that with the essential workers, I think truly meeting them where they are and educating the business owners themselves to say, not only for the business owners, but also the employees, this is what COVID-19 is. And then have certain requirements of business owners to say, you have to supply this basic level, at least, of PPE. And whether that's gowns and masks, face shields, hand sanitizers for sure. And then also, though, in the same token, making sure that the employees understand that even if I have a mask on, I can't touch my face. Just because I have gloves on doesn't mean that I can touch my mask and adjust it because my gloves are contaminated and I can directly contaminate myself. And then as far as allocating the resources, again, if you already know that Santa Ana and Anaheim are high risk, then put the test there yesterday, right? Get the resources there yesterday. Take masks there yesterday. Take food. Don't even have them have to come to you to say that I don't have food. We know that, COVID-19 has caused a health crisis, but an economic devastation. And the hardest hit communities were already struggling to keep up before it. So,
yes, and we've had record drawdowns on our food banks, and we can't do enough. We're trying to keep up with this. Now, we have to end it here, but it's so great talking with you. And, to know that you're out here taking so much of your knowledge and taking the time to educate us when you've been spending long hours in the ICU and you are dealing with the pain of families directly, one-on-one, going through this difficult time. And at a time when we have protests in our cities, that you personally are coming to explain how we can do better. I am so grateful. So I want to thank you. It's been a joy getting to know you, and I'm going to keep checking in with you so that you can advise me on how to be a better council member. And I want to thank everyone who joined us tonight and everyone who's going to be watching this on YouTube. And I'd like to invite everyone to follow Dr. Hilton on Twitter. She's amazing. And you can find her at Ebony Jade Hilton. And I also want to invite everyone to like my Assembly Campaign Facebook page at Melissa Fox for California. And you can also find me on Twitter at Melissa Joy with an I, Fox. And please sign up on my campaign website at votemelissafox.com. Lastly, I want to invite everyone to join us for our virtual fundraiser on June 3rd at 5 p.m., hosted by Assembly Member Monique Limon. She's Vice Chair of the California Women's Caucus, and it's co-hosted by Senator Connie Leyva, Chair of the California Women's Caucus, sponsored by NARAL, by Planned Parenthood, California Women's List, and RSVP to votemelissafox2020@gmail.com, and we'll provide the Zoom meeting ID with your RSVP. I also wanted to invite everyone to our virtual travel theme fundraiser with Lieutenant Governor Eleni Kounalakis on Thursday, June 18th at 5:30, and RSVP to votemelissafox2020@gmail.com. Zoom meeting ID provided with RSVP. I think I've read all of the parts that I'm supposed to, but I really want to say thank you to my incredible staff who put this together, and for all of the amazing work that Dr. Ebony Hilton has been doing. You are profoundly inspirational, and I am much better for knowing you. So thank you so much, and good night, everyone.
Bye, you guys.
Have a good night and get some rest. I'm sure you need it, although you look amazing.
Well, no, thank you. Look, seriously, this was fun. That went by really quick. But
I'm so glad.
Yeah, but if you need anything, if people say they want a part two, I'm more